and welcome to the Home of Medicine podcast with me, Dr. Amie Burbridge.
And with me, Dr. Ben Lovell. Hello.
Hi, Ben. So I forgot to say, this is a podcast in association with the Royal College of Physicians, Edinburgh. So, Ben, I've got a case for you. Are you ready?
Yes, please. Go.
Okay, so this is a 59-year-old female who presented to the emergency department with a 10-day history of viral symptoms. She describes a cough, cold, fever, headache, off of food, generally just feeling grotty. Now, I saw this patient in the winter months, so, we see this a lot, don't we? In ED and in AMU and SDEC or wherever we work. It's very frequent presentation. So, whenever I sort of hear this history, my first thought is, this is a virus. Would you come to hospital with a virus? What else is going on? What about you? Any particular thoughts?
Was this a referral from the emergency department?
It was.
Yeah. So I agree with you. 10 days of viral-like symptoms. It's a virus. Next. But what makes me a little bit intrigued, I guess, is why did our colleagues in the ED feel it's necessary to refer on to the acute physicians? Because there's one thing that ED are very good at. It's sending people home with common or garden winter viruses. So my question would be, hopefully without any signs of sort of sarcasm or any gender, but why did ED refer this to us? What am I missing here? Because they need the bed space, and they could have turned this around in a heartbeat. So there's obviously a little bit more to the story.
So I'm only going to give you one blood test. Okay.
Don't be dimer, please.
No, it's not dimer. But this is the reason for the referral to the medics.
Yeah.
CRP 606.
Oh, I love cases like these. We did an episode like this a long time ago. As there's sort of, what is your upper limit, your comfort limit for a CRP, especially for viral infections? All right. Thank you for that information. So was that the reason for the referral?
Yeah, well, I mean, she wasn't very well, but there wasn't,
Sure.
Observations were okay. But when you look at the CRP of 606, I always remember way back when in that episode, you said to me, if the CRP is 300 plus, 400 plus, think abdomen.
Did I say that?
You did.
Oh, okay. Yeah.
And I remember that. So she came down to our MAU and she was on intravenous antibiotics, Coamoxiclav, and with a CRP of 606. But our role and the reason for referral was to try and identify the source of the infection, because that had quite been identified. So.
Right. Okay. I love it. All right. This is the kind of case that really, really interests me.
Yeah. Absolutely.
So I need to go and talk to the woman and say, what is your history?
Absolutely.
And I will ask questions, but what I'm really asking her is, where are you hiding an infection from me? Her symptoms, I will try and drill down on. The S-bar, the handwave I'm getting is that I got cough, I got cold, I got fever, and I got headache. So maybe it was a viral infection, and as my grandma might say, it went to her chest and made what we call a superadded respiratory bacterial infection. So she might now be in a pneumonic phase of what started off as a viral illness. Cough, cold, fever, headache. Ooh, I mean, we've got to make sure she hasn't got herself a meningitis or a CNS infection as well. That started off with something like a simple viral infection. And of course, I will examine the abdomen, but I think this starts with a good old-fashioned history, please.
Absolutely. Okay, so on questioning, the reason she'd come to hospital originally is, although she'd been unwell for 10 days, she'd actually had a fall. And she'd had a fall and she was unable to mobilise when she'd fell to the floor. This was the day before I saw her. She'd been on the floor for quite a little while, was unable to get up, was unable to mobilise due to weakness and some pain. And she eventually managed to call an ambulance, 999. The 999 crew came and they brought her into hospital. Now, on further questioning, she said that she was pottering along in the house. And she had quite significant pain in her right hip and she fell. And she doesn't remember injuring herself or she didn't bang her head. She doesn't remember losing consciousness, but she just remembers just feeling weak and lying on the floor. She denies any chest pain, any shortness of breath, any abdominal pain, any diarrhea, any constipation. She had a little bit of urinary frequency, urgency, and dysuria, and her appetite wasn't as good as it normally was. But she remembers vividly that she was walking and just sort of, sometimes patients will say to me, when they've had a fall, their legs just gave way. I'm like, did you trip over anything? No. Did you lose consciousness? No, I just went down. So on further questioning, she lived alone and was fully mobile, absolutely no issues. She had a past medical history of osteoarthritis and hypertension and took amlodipine and paracetamol PRN, but nothing else of note. Had no known allergies that she was aware of and was a non-smoker, drank alcohol, quite a bit of alcohol actually. Probably, she said, around 2 to 3 bottles of wine per week. But no smoking. She worked full time, a sort of an admin type role. No family history of anything significant of note, and hadn't been hospitalised in the past. What are you thinking about?
Though, I'm getting the history of presenting pain just fixed in my mind. She's 59 and she had a fall with a long lie, and the reason for the fall is legs gave way.
Yeah.
She felt too weak to get up. And did you say hip pain pre or post fall?
Difficult to identify, if I'm being honest. So she had hip pain, right hip pain, and the pain went down to the knee. Now, I was finding it difficult to elucidate. Did this pain start before the fall and cause the fall, or did the pain start after the fall? Now, when looking at the A&E notes, it said, patient's right leg is externally rotated. Could this be a hip fracture? And they'd actually done a CT hip.
Oh, okay.
Which is normal.
All right. So she further, and what I was thinking originally, 59 is not old, and it's too young for someone to have a fall and a long lie. And I did wonder, I was going to ask you about alcohol, because sometimes that can be the factor which means someone who looks on paper to be quite young to fall over and spend a bit of time on the floor in the context of intoxication. And maybe that's still got something to do with it, because 59 is just it's too young really to go all weak and all wobbly and all of a doodah and fall over and not be able to immediately get up and go, ow. That's not, doesn't quite fit unless there was alcohol in the picture as well. So that's one thing I'm thinking. And a hip pain, which may or may not have been a sequelae of the fall, and the CT hip's normal. All right. And the CRP, actually, let's park the CRP for now. Let's stick with the history. Anything else I want to ask? So did you say, and all of this was on the back end of 10 days of a viral infection?
Yes.
Yeah? Okay. Fevers, cough, cold, and all that sort of thing. All right. I'm happy with that. And did she walk into the hospital?
No, she wasn't able to walk. And the ambulance crew got her up, they put her onto a trolley, and they brought her into the ED department, and she hadn't been able to walk since she'd been in either a trolley or a bed. I find incredibly useful is we have access to the ambulance.
I was going to ask, any insights from the crew?
So,
right, some really cool stuff in there.
So interesting, yeah. And I think when we are clinically reasoning and we're in that sort of first stage of gathering information, that information has to come from everywhere. And I find the ambulance information sheet a font of information and knowledge. So yeah, there was some information on there. They said that they found her on the floor, that she had a temperature when they saw her. Her temperature was 38.4 when the paramedics saw her. She had a heart rate of 141 when they saw her and picked her up in the ambulance. But her blood pressure was okay, respirated, oxygen saturations were normal. GCS was 15. They commented that she was unable to weight bear due to generalized pain in the lower back, in the spine where she looked like she'd fell, but also in the right hip and the knee. So this hip pain and this knee pain was coming up again. But also she was very coryzal, just looked fluey. Weak, exhausted, didn't really have any other information on there, apart from the fact that she lived alone, that her house was lovely, there was no safeguarding issues, which sometimes I think is really helpful when you read the ambulance notes, is they will often comment on what the house is like. So is it very clean? Is it dirty? Does it look like, there's a dirty washing around? Are they eating? And it's very helpful. But no, there was no concerns raised at all.
All right. So I think I've fleshed out the history as much as I'd like now. Before we come on to the investigations such as the CRP and the CT hip, we need to lay our hands upon this patient. And I would like to examine her. And I want to examine her chest and I want to examine her abdomen, but I want to do a neurological exam of her limbs.
Okay.
Yeah.
Why?
Well, she's not walked. Are her legs working? Gosh, you can tell I'm a highly trained clinical professional, can't you?
You can tell I'm neurophobic. I'm like, neurology, you need why?
Clearly, legs working. Has she got a subacute or acute neurological event? Has she had a stroke?
Hey? Oh, yeah.
Has she fallen over and has she got cauda-equina syndrome? Has she fractured some vertebrae? She's got spinal canal compression, and so yeah. I want to know why she has. Why did she not get up off the floor?
Yeah.
Anyone should be able to get up from the floor.
Yeah. And it's just made me think about when you said cauda-equina, bowels and bladder, which just came into my head was, did she have sensation? It's really important, isn't it, to ask about, do you know when you need a wee and a poo? Which, again, very simple questions. Okay, so on examination, when I saw her rest rate was 18, her saturations were 96% on air, BP was 118/74, her temperature was 37.3, heart rate was 97, GCS 15.
Okay.
Chest was clear.
Yeah.
Heart sounds were normal. There was no palpable lymphadenopathy in the neck that I could identify. On examination of the legs, the right leg did look externally rotated and the knee looked a little bit swollen. And she said that the knee was sore and painful after the fall. But apart from that, I didn't do a neurological examination, which I should have done. And thank you for highlighting that, because you're absolutely right. And I think that's one of the things that I miss, and I'm sure others do. And again, it's my fear of neurology is when somebody has a fall, it's really important to examine their neurological system. And I do, but maybe not every time, and I didn't in this case. So that is my bad.
There are a few triggers in my head where I just think, always do a neuro exam. One of them is headache. One of them is back pain. And the another one is legs gave way. And I'm not, listen, you should see my neurological exam. You'd be horrified, but I think I get the data I need. Can you move this foot? Can you feel me here? Can you let your leg, can you, let me hit you with this hammer. I'm just going to tickle the bottom of your foot here and watch what happens. But I think, it does give me as a screen, some really useful information sometimes. Even enough to say, there is no pathology which is related to the cord in this particular patient, for example.
Okay. Yeah.
All right. So I've got my history, I've got my exam. Now I'm going to do some blood tests, please. I know you've already given me some, but I'm just going through it methodically in my head. Is the full blood count okay?
White cell, 22.2.
Elevated.
Neutrophil, 20.56.
Elevated.
Urea, 22.6.
Ooh, elevated.
Creatinine, 243.
Okay, that's very abnormal. Yep.
CK, 4,834. That's the creatine kinase.
830. Okay, 4 digits. Yeah.
Lactate on the gas, VBG, was 2.1.
Yep.
pH, 7.31.
7.31.
Hemoglobin, 121. LFTs, normal. Clotting, normal.
Oh. All right. Do we have any previous renal function for this patient?
No previous renal function, no hospital admissions, presumed to be normal.
Okay. So she has either an AKI with a creatinine 243, or this could be her normal level as a CKD. I think her acute illness and the slight metabolic acidosis points more towards this being an AKI. In terms of why this could be an AKI, this could be pre-renal because she's volume deplete. I don't know how long she spent on the floor not drinking fluids. Do you think it was more than 12 hours?
I do. I wonder whether, because that CK of nearly 5,000, you wouldn't get that if you're on the floor for like 20 minutes. And it's difficult to elicit the time frame because she was unaware of when the ambulance came and when she fell. She said that it feels like she fell at night, and when the ambulance came, it was in the day. So maybe she was on the floor for 12 hours. Could have been less.
It sounds very vague. Very vague for someone who's middle aged, is not older or prone or vulnerable to delirium.
And I saw this patient with I can't remember, with another doctor, and they were like, I think she's got delirium. And I was like, really? She doesn't seem like she's delirious, but just not as, I guess, sharp as I would expected. But then she has got AKI, she's got a high CK, and the CRP 606. So,
right. Yeah. Okay. So I was saying AKI could be pre-renal due to dehydration if she was on the floor not drinking, due to the CK, which is toxic to nephrons. So that's contributing as well. Medications-wise, just the amlodipine, so nothing to blame on there. Could it be an intrinsic renal cause of an AKI, like an acute glomerulonephritis? Would be unlikely. Or could it be post-renal, i.e. ischial urinary retention? You didn't feel a big distended bladder or an abdominal exam, did you?
She did have a big bladder, absolutely. And I'm you're going to shoot me when I say this, Ben, but I did an ultrasound scan.
I don't mind you ultrasound. I'm glad you got a hobby. I think it's fantastic.
My new favourite skills. And it's really helpful because you can scan the kidneys to identify if there was hydronephrosis. There was no hydronephrosis, but she did have a palpable bladder. And you can actually measure how many mils were in the bladder. It was around 300 to 400 mils, so not a lot.
Oh, that's not so much. No. I think less than half a litre, I tend not to get too aggravated about that. So I think obstructive uropathy would be less likely here. So, all right. So I think she's got a pre-renal AKI. That's number one. Let me jot that down here. Pre-renal AKI. That's going in my assessment at the end. Now, then you gave me the CRP, which is 600. And at the moment, I'm jotting down after pre-renal AKI, I'm writing down V high CRP of uncertain cause, just as a note to myself. Sometimes I do write that as a diagnosis, by the way, in a clerking, if I really don't know. But at the moment, aide memoire. All right, then. So they're my blood results. Now, I'd like to do some imaging. I think I would like a chest x-ray, please, based on that very high CRP and a recent cough.
Normal.
Thank you. I know you've given me a CT hip already, but how I would approach it is a plain x-ray of the pelvis and the hip joints to look for a fractured NOF. And I'm assuming that was normal, hence the subsequent CT.
So there was a x-ray of the hip and the pelvis done earlier. And the report from the from the x-ray of the pelvis is normal. And it comments that there's a possible fracture in the patella. But
in the what? The patella?
Yeah.
Blimey, that x-ray pelvis went quite low.
They x-rayed the knee as well. But I mean, it's not my area of expertise, x-ray knees, but it's commented that there's a line through the patella, potentially near fracture. But she didn't have the knee CT, she had the hip CT'd and the pelvis, which, as I say, was normal.
Okay, because my next question was, I was going to say x-ray pelvis, x-ray of the knee, please, because you said the knee was swollen.
Yes.
And the x-ray of the knee suggested a patella fracture. And then subsequently, you said CT of pelvis. Did you say CT knee as well?
No, CT knee wasn't done.
CT pelvis. All right. And that was normal. Okay. Okay. So let me write down. I've got pre-renal AKI number 1. I've got very high CRP of uncertain cause number 2. Number 3, query patellar fracture. Right. So
and remember, when I examined the knee was painful and it was swollen and it felt quite hot as well to touch.
And did you have a range of motion at the hips when you examined her?
The hips were okay. So first of all, I always like to examine the good side. So I looked at the left side.
Yeah.
And it wasn't a great range of movement because she was unwell and I think she was quite weak. But examination of the right knee, the right hip, she could move it. On examination of the right knee, it was reduced range of movement and it was certainly painful to move and felt warm to me. Yeah.
With clinical effusion?
Yeah. Yeah, I thought there was an effusion. And from my pre-rheumatology, from my pre-acute medicine days when I was a rheumatology reg, I was like, about 20 mils in there. I don't know how much was in there, but
Okay.
there was definitely an infusion there.
So what I've got now is prerenal AKI, very high CRP of unknown cause, possible patella fracture on X-ray, but a painful, effusive right knee. I'm going to reorder that slightly and now I'm going to say working diagnosis, query septic joint, query septic knee, needs urgent aspiration.
Okay.
That would explain a couple of things. That would explain the leg giving way, not being able to stand up again, the high CRP. Then I'm going to say number 2, AKI due to sepsis and dehydration. Then I'm going to say number 3, possible patella fracture. But that would be weird to have a fracture and an effusion the same side. It could be nothing, but I'm going to put that in my back pocket for now.
Okay.
So I've got to say my plan at the moment would be the CRP I might lay at the door based on what I've got of the knee. So I want number 1, IV antibiotics. Number 2, urgent aspiration of knee. Looking for signs of infection or signs of a crystal arthropathy. So gout can give you a super duper CRP and extremely painful knee.
Yeah.
Number 3, she needs some fluids.
Yeah.
So I prescribe some IV Hartmann's and then check her renal function maybe in 12, 24 hours. Number 4, I would be monitor her urine output. Just make sure she does pass urine. Number 5, I'll be repeat CK after the first 1 or 2 liters of fluid to make sure that it's coming down.
Yeah.
And number 6, I would say radiology opinion of the X-ray of the knee. Query further investigation such as CT required. There you go. That's my post-take plan. Oh, and of course, patient for full escalation of treatment and needs prophylaxis against VT prophylaxis. So
Okay. So 2 questions. You said antibiotics. What antibiotics would you like to use?
Right. I guess if you're thinking septic arthritis, you want to go for something like Fluclox. However, I'm going to keep it nice and broad. And at my hospital, broad spectrum antibiotics for fever of unknown origin. So sepsis of unknown origin is IV cefuroxime. So some of that, please.
Okay, so you're going to use IV cefuroxime because you're still not sure where the fever's coming from. So you're sort of a fever and CRP of unknown origin. Okay. Do you want to do anything with this abdomen? Because, I remember you telling me before, high CRP, think abdomen.
Her abdomen was soft and non-tender with a distended bladder, no organomegaly, and obviously no signs of rigidity or peritonism at all. So you're saying to me, do I want to do a CT abdo-pelvis as a look on an infection hunt? I might, but you know what? I'm going to tap the knee first. Let's not throw everything at the wall and see what sticks. Let's have an orderly progression of ideas.
Okay. Would you aspirate the knee, or would you get a specialty to do it?
Good question. I think probably I would get a specialist to do. I'd ask orthopedics to do it. Septic arthritis is an emergency. I have done the aspirations because I trained when it was on the curriculum as a procedure for a med reg to be able to do. And I used to work in a DGH in the Lake District where you did everything. So you'd stick a needle in and see what happened. Whereas now I don't think, and rightly so, I don't think patients or hospitals tolerate, let's stick a needle in and see what happens. That's not how we do things anymore. We have people trained up to do things safely and to be successful the first time. Yeah.
Yeah. Okay. Absolutely. So there is nothing I love more than putting a needle in a knee. Because I did do rheumatology and I do still love it. I think it's like a bit of a passion of mine. So we aspirated the knee. And out of this knee, for the first time in my whole career, came frank pus.
Wow.
I had never seen anything like it. So I've seen quite a lot of septic arthritis, but I've never seen frank pus like that. It's normally been synovial fluid, is maybe a bit of turbidity, but this is pure pus.
What did it look like? Just like cream?
Yeah, it's like cream. It's like greeny cream. It was like snot.
Wow.
Yeah. It was really like, wow. And just on that note, my favourite question, why is snot green? And why is pus?
Oh, why is it? It's got something to do with myeloperoxidases in bacteria causing green. I don't know. Something
So
to do.
So the cytoplasm of a neutrophil, where it is green. So if you've got huge amounts of neutrophils, which you have in some snot and in pus, it gives it that greenish tinge. So anyway, I've not seen anything like this. I was like, and we put it in some, we sent it off for analysis, but I made sure that a lot of people around the day saw it, because I think it's a really important learning tool to actually see what it looks like.
If I can just insert a tiny anecdote here. I remember a long time ago, I was doing a lumbar puncture, and I very clearly, on a young Polish woman who came with a really bad headache, blinding headache, and I put the needle into the CSF, and the CSF came out, and it looked like cream, twisted cream, just frank pus. No wonder she had a headache. Imagine that all bathing around your meninges. I said to her, "You're the toughest person I've ever met." But yeah, you just remind me of that when you talked about your knee aspiration experience.
Yeah, it was not seen anything like it. So we sent the knee aspiration off, and we sent it off for urgent gram stain, microscopy culture and sensitivities. And we also sent it off for crystals. So we look for calcium pyrophosphate and uric acid crystals, so gout and pseudogout. And we started antibiotics. She'd already had 2 doses of intravenous coamoxiclav in the emergency department for a presumed, probably UTI potentially. But
UTI, okay.
But I started her on intravenous flucloxacillin and clindamycin, which are actual guidelines for septic arthritis. And I did that because I had the pus in front of me and I was convinced it was a septic arthritis. So we sent the sample off for analysis, and we spoke to the orthopaedic doctors, and they came down very rapidly and took her to theatre, where she had a knee washout.
Yeah.
Now, what was interesting about this is what it grew in the knee. So one of the most common causative agents that we see in septic arthritis is Staph aureus. And it's the only thing I've ever seen grown in the joint. She grew Streptococcus pyogenes.
Okay.
So about 8 to 16% of septic arthritis is caused by strep pyogenes. The rest tends to be staph.
Okay. What percent did you say? What percentage was strep?
8 to 16%.
8 to 16. Okay.
Yeah. Is strep. And it's a group A strep. So horrible septicemia you can get with group A strep, as we all know. And it's known to have quite a high mortality and morbidity associated with strep pyogenes, arthritis, because it can rapidly destroy the patella.
How rapidly? In days?
Days. Yeah.
Okay.
Days. So the notes, however, from the theatre say that the patella didn't look very nice. So there could have been potentially some damage there.
So maybe that's what they were seeing on the X-ray then.
Potentially. Yeah, potentially. Could have been. I really like this case, and I think there's a couple of learning points that I want to pull out from this, I think. And I think number one, we always, and I say this all the time, and we've talked about it a lot, when somebody is unwell with a fever and a high CRP, we automatically think urine. And I think that sometimes stops us from looking at other sources of infection. So it was presumed that she had a urinary tract infection, and she was given antibiotics, coamoxiclav, as per this. But actually, she'd had investigations on her hip and her knee because it was painful. Do you think because we don't see septic arthritis very often that we don't maybe think about it and we go for common things are common, let's treat that?
Well, I certainly think UTI is overdiagnosed. And one big step change I've noticed in my career is the Ditch the Dip campaign, which is stop dipping urine in patients over the age of 65 because you end up over-treating asymptomatic bacteria and it's not always a UTI. And these poor older patients who may be more frail and more vulnerable, they come to us with all sorts of infections and they get sent home with nitrofurantoin or trimethoprim or something because we go we immediately go towards urine. And also that whole thing about when people take the history and they notice that the urine was more smelly than usual. The patient smells of urine. I'm like, you cannot smell nitrites. You cannot smell leukocytes. If someone has had the bad fortune to be urinary incontinent and they're still sitting in the same clothes, they will have a strong odor. but you cannot diagnose UTI based on your nostrils. And that's something that I'm always sort of pushing against. So I do think we stop. I think for septic joints and things, the patient usually declares to you the joint in quite a loud voice because it's agonizing. And it takes quite a lot of determination to ignore a patient whose knee is bright red, cannot be moved a single degree in any direction, and they're saying, "Ow, my knee, my knee." Now, where it goes a bit funny, I think, is sometimes in patients who can't give you that information. So patients who are confused, delirious, have dementia, cannot speak for any kind of reason. And it then relies on us actually lowering the bedclothes and having a look ourselves. So if you do have a patient with an infection of unknown origin, or even a HyperCRPaemia of unknown origin,
like that? Yeah.
you have to do a proper examination, and that is examining the patient from their heads to their toes. And you'd be amazed at what would be lying underneath. I remember when I was an SHO and my consultant saying, "Oh, Ben, you've written down here infection of unknown origin. You know there's no such thing. All you've written down is infection and you haven't properly looked. Go to the patient's bedside, strip them naked and examine every inch of them." And lo and behold, I found an abscess on his back that I hadn't seen the first time around. I don't subscribe to the theory that all infections will be made identifiable by stripping every patient naked and looking at every part of their body. But I think we do have to be thorough in our investigations, and it is very, very easy to look at CRPs, look at patient demographics, and then jump to a heuristic in the wrong direction and say, "How about I treat you for an acute trimethoprim deficiency," and sending them home again.
Yeah, and what was interesting about this is that when I looked at her knee, it was a bit swollen, it was a bit red. But I've seen septic joints which are really painful, really swollen, really red. It wasn't. It wasn't that angry. It didn't, when I looked at it, it didn't shout septic, septic, septic at all, whereas I have seen some knees in the past or some joints which have. But she did, the risk factors of septic arthritis are joint disease, and she did have a little bit of osteoarthritis.
Yeah.
So, could this have increased her risk? She'd had a recent viral infection. Had she got was this a bacteria? Did she have strep throat? And did she have some hematogenous spread potentially to the knee? Her blood cultures were negative, but again, her knee culture was positive.
Yeah.
So she made a very good recovery. So she had the operation, she had antibiotics, and she did get a lot better. What was interesting is when I was looking at the guidelines for a hot joint, they were last published 20 years ago.
Okay, good. I haven't got to learn anything new. Fantastic.
No,
It's all the same.
It's the same. So British Society of Rheumatology published the guidelines in 2006. There was a discussion in 2017 about the utilisation of procalcitonin and corticosteroids in patients with septic arthritis, but there was no consensus. They are undergoing revision. So the new guidelines are going to be released potentially this year. I'm not entirely sure when, but that's what the BSR website says. So the guidelines back in 2006 were exactly what we talked about. Aspirate the knee, try and do it before you're given antibiotics, but don't delay antibiotics if you're waiting for the knee aspirate to be done. Pain relief is really important, and very, very quick utilization of antibiotics, whichever your trust uses, and then send the samples off appropriately for cell count and gram stain. So just an interesting case. And what was interesting as well, just another little learning point that I want to pick up on, is a hemoglobin steadily dropped throughout admission. So why do you think that could be?
Why did her hemoglobin drop throughout admission? How low did it go?
90.
And it wasn't just she got very vigorous IV fluid resuscitation. It was all sort of transient dilutional.
Okay, yeah, that could be. Yeah, that's a really good point. Could be dilutional. When you could look at you can look at the hematocrit, can't you? And if the hematocrit goes down quickly as well, then that could take dilutional. So that's a really good point. Could be. Yeah.
Any reason why she would hemolyze I can think of? I can't think of anything. Is she bleeding from anywhere? I can't think of anything. No, can't think of anything else.
So there was no acute blood loss that was noted, and hemolysis can happen in infection sepsis.
Huh.
So if she is hemolyzing, we do a blood film, and we could also look at LDH levels to see whether there is any hemolysis. So there is a condition called anemia of acute infection.
Oh, right.
Uh,
because the bacteria consume all of the iron, something like that's when they multiply so rapidly.
So sort of. So when you've got an infection, the liver produces hepcidin.
Yes, it's all coming back to me. Are you going to say macrophages in a minute?
Yes, I'm going to say macrophages.
Yes, the macrophages do something with your iron, but keep going. It's all coming back
They
to
do,
very
absolutely.
slowly.
Yeah, so I'm just going to cover a little bit of this. So hepcidin, which is one of my favourite words in medicine, normally regulates iron homeostasis and iron metabolism and keeps it at a beautiful level. Now, what happens in infection, sepsis, is you get higher levels of hepcidin triggered by inflammation or infection, normally interleukin-6, which is a pro-inflammatory cytokine. What hepcidin does is it inhibits iron from entering the bloodstream. And the reason for this is that often bacteria need iron to grow. So the body's really clever here, and it tries to keep hold of its iron so as it doesn't feed the bacteria, so as it doesn't feed them and, help them grow. But actually what happens is the hepcidin stops any iron entering the bloodstreams, and therefore, if you haven't got any iron, you've got no transferrin, you've got no store, so no ferritin, and you can't produce hemoglobin, and you become anemic.
Do you know something really embarrassing? I wrote this on a curriculum for a teaching program about 10 years ago. I remember writing learning materials for an online training module about this exact condition, and it's just gone. But I remember now you say it.
Doesn't it?
Yeah.
Yeah. So I just find it really interesting. I'm not necessarily saying that that's the cause of why she was anemic, but, I think when somebody's in hospital for a long time and we see their hemoglobin trend down from maybe 120, 130, they've had an infection and it goes down, we go, oh my God, they've lost blood, or why are they anemic? But actually it could be due to this.
Yep.
Acute hepcidemia.
Brilliant. I love it. Do you know what? I really, really enjoyed that case. I love cases like this on the acute take. I really, really love it.
Yeah.
It feeds something in my soul being able to do this. And so I'm quite pleased that I sort of got the diagnosis, but it really is, I find it fun. It's like playing a game. It's like trying to find out and use your detective skills to work out the diagnosis. And it is proper old fashioned medicine that I really, really enjoy. So thank you so much for bringing me this case.
Thank you so much, Ben. And from me, I think I've learned 2 new things. HyperCRPaemia. No, isn't it a hyperCRPephilia?
I just said HyperCRPaemia. It's a word I've made up. But because it's high CRP blood, emia.
Oh, right.
High CRP in the blood. You see? Yeah,
You've
you can
just
have
been
that. Take that.
Thank you very much. Thank you. So, a massive thank you, Ben, as ever. I hope everybody listening enjoyed that. Please rate, review, subscribe to our podcast. Please get in touch. We absolutely love hearing from you, and we do reply to all the emails. And if you've got any suggestions about anything that you'd like us to cover in the podcast, we would be more than open to suggestions. So thank you, Ben. Thank you to everybody out there. Thanks for listening.
Bye.